This is David Harden from Minneapolis, and I want to thank you for watching this epithelial ingrowth production. I want to also thank TLC Vision for making this possible in the May 2002 ASCRS meeting. Epithelial ingrowth is unfortunately a not too uncommon problem that can cause significant visual disability. As you see here with this plaque-like epithelial ingrowth, it's obvious that this epithelial ingrowth would be requiring removal and would be visually significant. Most of the time, epithelial ingrowth occurs because of the fact that the patient has an epithelial defect at the time of the surgery, oftentimes associated with anterior basement membrane dystrophy, but it can occur for other reasons as well. When it occurs, oftentimes it's not even visually significant, just causes a small area of abnormal epithelium at the periphery and doesn't lead to progressive epithelial ingrowth requiring removal. But in some patients it does go on to distort the topography and therefore distort the vision, and it's at this stage that it requires removal. Epithelial ingrowth, if we approach it early on, oftentimes is not much of a clinical problem, and again stays limited to the periphery in many patients and doesn't even require removal in some of those patients. In some, though, it's progressive and then eventually requires removal, and I tend to remove the epithelial ingrowth when it reaches the point that it encounters about a 7 millimeter optical zone. That way, if there is any tissue loss from the epithelial ingrowth, because it can oftentimes erode the back of the flap, then it still is outside of the area that's responsible for the vast majority of the vision. As you can see here in this slide, epithelial ingrowth is more common with an enhancement procedure, varying somewhere between 4 and 8%. Most of those cases, though, do not require removal because the epithelial ingrowth is small, peripheral, and isolated, and it doesn't cause progressive loss of vision or progressive epithelial ingrowth. But this is still much higher than you see with a primary case, and therefore it makes you want to do everything you can at the time of an enhancement to try to prevent epithelial ingrowth. I'm going to demonstrate our enhancement technique again for you, just to try to help show you what we've done to try to reduce the epithelial ingrowth rate. We use this special hook. What this does is it cleaves the epithelium evenly. We identify it at the slit lamp, again trying to minimize the epithelial disruption with an enhancement, much like you see in a primary case. So under direct observation, we then can make an indentation that's straight up and down in the area of the flap. It's easier to identify it, especially if the patients are out a long time. We then use the second side of this instrument that's made by Ryan for me, and is a enhancement tool. We use that second instrument, the second side of the instrument, then to create a small pathway underneath the flap so that it's easy to identify it at the time of the surgical operation. The patient is then taken and laid down at the laser, and the surface of the cornea is dried off. And then another instrument, also made by Ryan, called the SIBO flap elevator, is then utilized to break the epithelium all the way around the periphery with this device. And what this does is, again, attempts to cleave the epithelium as sharply as possible in the periphery to prevent little tags of epithelium from becoming displaced and or becoming positioned underneath the flap. Then once the periphery has been cleaved with this SIBO flap lifter, the second end of this is used, which is a lamellar dissection tool, and then this is used to break any central adhesions. In this patient at the slit lamp, what I'm doing is just beginning the lift with a 30 gauge needle, and so what I like to do is cut for just about a clock hour along the border of the flap. And I think this is much more important for the larger flaps, such as the Hansatome flap, because of the fact that the adherence is much greater and it's much more difficult to see the edge of the flap. One of the things that makes it difficult oftentimes is the fact that the adherence is so great, and so you can see towards the end of the tape there that I do turn my needle sideways and lift the edge of the flap to make sure that I can get my instrument underneath it at the operating microscope. I'll replay that segment again so that you can see it again. I'll identify the edge of the flap, and this can be used for either ACS or hot stone cases. Just slice right at the very edge of the flap with the 30-gauge needle to try to just cleave the epithelium so that you don't tear up the epithelium. I think it's much cleaner than doing it at the operating microscope, at least starting it. I turn the needle over, and now what I'm doing is just dissecting underneath the flap, and then I'll lift the flap right there at the very, very end. And that way I have a flap edge that I can identify at the operating microscope. This is yet another patient that I'm going to lift the slit lamp. Here you can see this patient has epithelial ingrowth, and this is one of the reasons that it's nice to be able to identify the exact edge, is to help reduce the chances of epithelial ingrowth. And again, one drop of anesthetic, 30-gauge needle just used to slice the epithelium, hold on to the upper lid, and then go underneath the flap edge to just make sure that you can lift it just enough that in the operating room it'll be easy to identify where that flap edge is. And that's really all you need to do. In the operating room, I use a closed-bladed speculum, one additional drop of anesthetic. Closed-bladed speculum is useful for any enhancement, just to try to keep the lashes out of the way. And after the extra drop of anesthetic, I'll typically dry the extra material off of the surface of the cornea with another moist Maricel sponge. It also allows it to be a little bit easier to identify that cut edge, and you can see it down at the 6 o'clock position. And so then I'll take a lamellar dissecting tool, and you need one that's fairly thin to be able to get in underneath that flap edge and try to break the central adhesions. And if you're going back for an enhancement relatively early, breaking the central adhesions is not quite as crucial, like if you're going back at a month or whatever. But as you get further out, towards a year, year and a half, then it's very important to break those central adhesions so that you don't tear the flap with the flap lift. And then I'll grab the flap edge with a Hoskins forceps so that it's not too toothed, and then I'll lift the flap edge, trying to very carefully cleave the peripheral epithelium in this specific case here. And then one of the problems in any kind of enhancement where you're lifting that same flap is that the epithelial edges will oftentimes be adherent to the top part of the flap, and so it's important just to push the epithelium back out of the way. And again, this is a case of epithelial ingrowth in this specific situation, and so I'll make sure that I remove epithelium from the stromal bed in the areas where it was, but I'm also being very careful to make sure that the epithelium is back away from the stromal bed so that I don't lay that top flap back inadvertently over areas of epithelial cells. And so I'll do a little bit of light scrubbing here on the back surface of the stromal, or on the front surface of the stromal bed, and then also remove epithelium from the back part of the flap with both a Maricel sponge as well as a PRK spatula as we proceed throughout this case. But I wanted to mainly demonstrate the lifting of the flap, and I think that with this technique, the epithelial surface stays much cleaner, and it's much less likely to develop problems like epithelial ingrowth or irregular flap edges when you're trying to lift directly at the operating microscope, because the edge of the flap is just extremely difficult to see, even with some of the depression techniques. And again, here you see me removing epithelium from the back of the flap.